Hello, ladies and gentlemen. I wish present to you the dramas which we experience in everyday treatment of osteoporosis in Poland. The figures are very striking. The national data, we have 2 million patients with fracture. In Poland, only 3% of them is treated, and only 2% are treated after the fracture. The mortality 6 months after proximal femur fracture in women is 28%, and in men 32%. This is unfortunately the highest percentage in Europe. And the prognosis is really bad. In 2035, due to aging population, we expect to have 4 million patients with osteoporotic fracture because the elderly population will reach 27%. We know that it can be changed, and it was done in the United States. We see a declining number of proximal femur fracture in spite of aging, of course. And the reason for that is the reimbursement of the DEXA scans and access to the medication. In Europe, we have all possible medication for osteoporosis treatment, I mean anti-resorptive and anabolic agent, but it is not for Polish patients. In fact, only weekly alendronate and risdiplam are just available steroid. We have no alendronate at all. The denosumab is funded in very limited number of patients, and no single anabolic medication is now on in Polish pharmacy. How we should change the situation? First of all, we are proposing DIY. That means calculate your risk using Frax calculator on portable. Go for osteoporosis.pl and make the text, and you got results. We are proposing the DEXA scan should be under GP disposal, not only in specialist register, because there is a long, many months queue for specialist visit, and they are not very keen to pay for that. How to increase the number of patients after the fracture? There is answer for that. It's MLS, Fracture as a Service. We are celebrating 8,000 of those institutions in the world, and we have striking result in Scotland. 97% is treated. We have 40% reduction of proximal femur fracture in states, and we have 30% reduction of the mortality. What about the medication? The first is to sharing generic zolendronate, which is really cheap. The cost is 100 zloty, what is plus $22 per year, and efficiency is similar to other bisphosphonates. It is now the standard of prescribing after the nosotization. We would like to give our patient more innovative medicine, especially the denosumab, which is a better gain of BMD than alendronate. And we would like to have romosozumab, as we know, is the medication which should be prescribed in a very high risk patient, means just after the fracture. And in the clinical trial, it is head-to-head. The reduction of proximal femur fracture was higher in romosozumab group than in alendronate group. Saying that, thank you much for your attention. Thank you.